I've been somebody who's been working in palliative care for over 30 years. I'm a nurse by profession, and now I do research in the area. And in the course of my clinical work that I do, and in the research that I do, I've been told by many dying people about their wishes to die, and I've learned a lot about why people have a wish to end their lives when they're faced with a terminal diagnosis. Many people would wish to be like this woman. Her name is Isabel Milko. And Isabel lives in her own apartment. She cooks her own meals. She does her own grocery shopping. She does her own banking. She has no signs of cognitive decline. She has no chronic illnesses. She's on no medications. And she's only, in the context of her life, only been hospitalized twice. Once was for a cataract, and once was 2 years ago when she fell and fractured her pelvis. And to the amazement of the medical and nursing staff, she walked out of the hospital a week later. Isabel Milko celebrated her 104th birthday in January of this year, and what her wish was for her celebration is that she could have all of her family and friends surrounding her. There were 60 of them, to all have dinner together at her favorite Chinese restaurant called the Ho Ho in Kenora, Ontario. And Isabel Milko also happens to be my grandmother. And I surely hope that I have her genes. She is the most inspiring person that I have the pleasure to be connected to. Unfortunately, and she is actually the picture of healthy aging. And unfortunately for many Canadians, growing old doesn't go this way. Many people have multiple chronic health challenges, and many people have experiences with the healthcare system that are slightly problematic. This was particularly the case with a gentleman named George Cook, and if you can't read it, I'll tell you what it says. Staff members at the Parksville Care Home, where George Cook lived out his final years of life, were in tears after learning that their elderly friend had died on a stretcher in the emergency room at the Nanaimo Regional General Hospital. According to George's daughter, she found her father alone, cold, shivering, and soaked in his own urine, lying on a stretcher positioned by the ambulance entrance doors. He died 7 hours after arriving in the emergency room, never having been seen by a physician. While many Canadians have an idealized notion of dying at home, the kind of peaceful kind of environment surrounded by family and friends, in reality, the large majority of people die in an inpatient setting, most of those in acute and residential care setting. Research tells us that dying in acute care is strongly associated with the intensification of care at the end of life and results in worse quality of life for the patient in the final days, a worse quality of death for the patient, and an increase in stress, anxiety, and post-traumatic stress disorder in family members. For those of you who were here this afternoon, Doris Barwick kind of had almost the same slide with the same picture, and that's because we're out giving the same message. People also die in residential care, and despite the fact that it is to be considered home for many older adults, in the last stages of their journey, residential facilities still remain highly institutionalized and hospital-like. More seniors are living their final days in residential care than ever before, yet research highlights the challenges in implementing appropriate end-of-life care. In residential care facilities across Canada, almost 50% of residents have received drugs identified as inappropriate and potentially dangerous. Pain and other symptoms are poorly managed. Communication between staff and family members is fraught with difficulties, and sometimes unnecessary hospitalizations occur. Staff shortages, recruitment and retention issues, reliance on sometimes untrained staff to provide end-of-life care make things very difficult. And it is then so we it's not any wonder that most Canadians, when asked, say that they would prefer to stay at home as long as possible, including right to the end. The paradox is that while most people desire to remain in their own homes, so very few do. In Canada, as in many countries, one of the primary goals of palliative care is to support people to die in their own homes. When it comes to dying, there's no place like home, as it is said. In a view reflected in law, poetry, and cliches, home is commonly taken to be a refuge, castle, haven, or nest. It is argued that home is where people feel most comfortable. Home represents a place where we can be at ease, away from the pressure to conform to social norms. For many people, home is where they feel most truly themselves, the very center of their life, and their closest relationships and most intense emotions. And as such, home is their natural telic place where mature selves are revealed. Current conceptualizations of home provide an attractive alternative to institutional-based care. Aries describes an institutionalized death as an unnatural experience. The death of a patient in hospital covered with tubes is becoming a more popular image. These views have advanced what I call the home death movement and have led some people to assert that care provided at home will be far superior to that of the depersonalized and paternalistic hospital setting. And so this evening I'm going to share with you some of what I've learned about dying at home after almost 15 years of studying this phenomenon. I will focus mainly on the impact to family members when they provide care at home and what we have learned about supporting them. I will also touch on what happens for people who do not fit the mainstream, those who are vulnerable because of structural inequities, and describe what home and end of life looks like for them. And in doing this, my hope is to inspire a sensitivity around notions of dying at home, family responsibility, and our obligations to care. Rosalind Carter said there are 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, or those who will need caregivers. Just so we're all on the same page, when I'm talking about family caregivers, I'm defining them as an individual who provides ongoing care and assistance without pay for family members and friends in need of support due to physical, cognitive, or mental health conditions. About 8.1 million Canadians, or 28% of the Canadian population over 15 years of age, provide care to a family member or friend with a long-term health condition. About 75% of all family caregivers are women, primarily older, frail spouses and older working children who have themselves age-related health problems. Family caregivers in Canada provide $25 to $26 billion worth of care annually and incur $80 million annually in out-of-pocket expenses. So family caregivers really have emerged as the principal source of support for people who are dying. Family caregivers play a critical but yet invisible role within the primary healthcare system in Canada. Caring for somebody who is dying at home is not without its challenges. Physical burdens include the fact that care for many people is often 24/7, sleep deprivation is common, and more than 50% of family caregivers who are caring for somebody dying at home have chronic illnesses of their own. Many caregivers describe isolation, resentment because of restrictions on time and freedom, and loss of privacy as particularly challenging. And as I mentioned, the out-of-pocket expenses can be profound. Many family caregivers give up paid employment to provide care and therefore experience a loss of income as a result. Prevalence rates for family caregivers in palliative care for depression and anxiety are reported to be as high as 39% and 46% respectively. And the risk for mortality for these caregivers experiencing emotional and mental strain is increased by 63% compared to non-caregiver control groups. So these are not minor kinds of health issues that family caregivers face in their obligations to provide care to a family member. I spoke this morning about how the whole notion of being at home and dying at home has really come into the kind of public foray. And while we often have images of based on some of what we know about what dying at home looks like, oftentimes we think of dying at home as a wonderful kind of experience for people, and it often is. But I'm going to talk a little bit about sort of an ongoing program of research we've had around family caregiving and palliative care. And one of the first studies that we did was this ethnography of dying at home. So basically, what I did was I interviewed about 60 family caregivers and another 40 or so healthcare providers, and then I spent about 350 hours or so in the homes of families who were providing palliative care. I was there in the morning, I was there in the evening, I was there in the middle of the night, and my goal really was to get a better understanding of what actually happens in the context of being a caregiver when somebody is dying. I saw many experiences that were highly life-enriching for people. People talk about a sense of accomplishment at fulfilling a final wish that their loved one has to stay at home, because for the majority of Canadians, if given a choice, most Canadians would choose to be at home when they're dying. Caregivers talked about how they're able to give something back to the person that they are caring for, that providing care at home helped people to find meaning in their situations and to be able to share intimate times that would be otherwise difficult within an institutionalized setting. At the same time that families talked about these life-enriching experiences, they also talked about how exhausting caregiving was, how difficult it was to recover from, and providing care to somebody at home includes making a number of sacrifices. I spoke a little bit this morning about how homes are recreated sometimes into hospital-like settings. The home environment is changed when palliative care is provided there. People talked a lot about invasions of privacy, and what I mean by that is for any of you that have experience needing support from the home support sector, there doesn't seem to be the ability to have the same person come and visit and provide support to families at home. Basically, what families describe to me is this kind of revolving door of different people that really puts people in a situation of having to all the time repeat stories. And in fact, where home support should be there to actually give people a break, families don't get a break because they don't trust the people that are coming into their home to provide care. Sometimes families talk about feeling pushed aside. And it was really interesting when I was in these homes and observing people, and I was a bit kind of bothered by the fact that some people would walk in without knocking on the door. Some people wouldn't remove their shoes. Some people just came into the home and took charge, and families talked about that kind of this kind of sense of, nobody's looking out for me, nobody's respecting what it is that we want here. And one of the interesting things that happened throughout the course of these observations was, in palliative care, we have this mantra that says the patient and the family are the unit of care. We care for everybody together. But when you watch healthcare providers come into the home, basically they focus on the person who is dying, and the family caregiver actually becomes the person that gives the report on how they are doing. And it actually wasn't all too often, although it did happen, that healthcare providers were actually asking family caregivers themselves, how are you doing? What is this like for you? What can we do to support you? People talked a lot about relinquishing their core identities and reinventing themselves. This woman said to me, it came to us having to fight all the time instead of my spending time saying goodbye to him. She was talking about her father. All that caregiving stuff that I have to do gets in the way. He was mad at me because I was the one that was inflicting all this stuff on him. When he was on the palliative care unit, I could just be there and support him. I guess your role changes when you're at home. Instead of your job being to just sit with him, spend time with him, comfort him, and hold his hand, suddenly your job is to look after their pain, their nourishment, their bodily functions. So you feel like you don't really know exactly what it is you should be. So why do family members, given all these burdens, make a decision to provide care at home? Well, regardless of the burdens, in fact, most families will still say, yes, I want my loved one or my relative to be at home because home provides an environment that is more normal and that they have a measure of control over. But one of the primary motivators that these caregivers talked about in terms of care at home was related to their poor experiences in hospital care, particularly in acute care. And I mentioned this morning that this actually seems to be around the period in which people are diagnosed with a life-limiting illness, and they've all went through all kinds of tests and all kinds of things that happen in acute care, and they basically say to their family member, don't ever take me back there. And the family member says, of course I won't. And of course, what's the implications then if family members take a loved one home and then are feeling very overwhelmed and burnt out, but they've made the promise? How do you actually break a promise and say to somebody, sorry, I can't care for you at home now when you're dying? It's a very, very ethically charged situation. Family members make promises to provide care out of a sense of love and obligation. Our media depicts dying at home in this wonderful terms of endearment manner. Everybody's wonderful, everything's peaceful, and we know from our research that that isn't often the case. And in fact, I would say that we have idealized dying at home into something that, unless you're a person who has experienced providing that kind of care, is maybe not as true as the movies tell us. We also have a very strong kind of sense that we have expectations that families should be there to care. And of course, families will always want to care. That's what families do. I often have people, when I talk to people in health authorities, to health administrators about their need to actually, provide more support in home care and for family caregivers, many of them say things to me like, well, like if we open the gates too wide, people are going to strip us of everything. And I keep saying to them, nobody wants us to come into their home. Like, they don't want people in their home unless they need the help. Family caregivers, it's a myth that family caregivers are going to take over and make us go broke in the healthcare system. Families actually have a strong desire to care. So when they ask for help, they need it. I had a research participant once say to me, she said, dying at home is like breastfeeding. It's the newest best thing, and you're made to feel guilty for not doing it. So we did that study, and one of the things that came out of this study is this idea that when studies have been done around where people prefer to die, oftentimes families, the person who is dying and the family member are both asked, what would you prefer? And in all the kind of popular kind of health policy literature, I could just tell you that every single statement will say, if the patient and family are given a choice, they would prefer to be cared for at home. And that's actually the case for people who are dying. They, of course, would prefer to be cared for at home. But in this study, we had we found that patients and family members only agreed about half the time on the preferred location of death. Many patients wanted to die at home, and many more family members wanted the patient to die in an inpatient setting. And I'm not talking acute care, I'm talking a well-designed residential hospice setting, which is often a good option for a lot of families. So once we finished that work, one of the things that I noticed in doing that research is that there were some family members that seemed to do really well with this whole caregiving at home, and there were some family members that didn't seem to do so well. And we were really interested in trying to understand, well, why is that? You know, there's an extensive research on the physical and emotional burdens associated with caregiving and palliative care. We don't really need to do any more research in that area. We understand that. But while some family caregivers are overburdened, some seem to fare relatively well. And so we thought that if we could understand what was happening for those people who were coping well with providing palliative care at home, we might actually begin to understand how we can help those who weren't coping so well. So I'm going to tell you about these caregivers who, we said seemed to be doing really well. These caregivers had a certain approach to life. They had this kind of just do it attitude. I'm going to take one day at a time, because to look too far ahead kind of freaks me out. So I can only handle what's in front of me this day, and yes, I want to be prepared, but I don't want to be too far ahead of the game. And these folks seem to really see the bright side of things. You might say in psychological terms, these are people who are highly optimistic in their state of mind. The other thing that seemed to really influence how people cope with providing care at home had to do with their relationship with the person who was dying. If the person who was dying had accepted the fact that they were going to die, that seemed to make things a lot easier than people who were really angry about their illness. It's really, really challenging as a healthcare provider to care for people who are really kind of raging against the fact that they have a terminal diagnosis. It's even more difficult for families in that situation. We found that strained relationships, even when people are dying, tend to continue to be strained. In fact, that is exacerbated, and feelings of resentment surface for caregivers because of the relationship strain. One of the things that was really important is that the person who was dying actually recognized the caregiving contributions of the person who was caring for them. They were appreciated for their caregiving efforts and treated in a respectful way by the person who was dying. One of the things that is like a no-cost intervention to support family members is to let them know that they're doing a good job. Because the one thing in palliative care that families are deeply, deeply scared of is that they're going to give that last dose of morphine and somebody's going to die, and they think they will have done something really, really awful. People need to be reassured. Those family caregivers who seemed to cope really well tended to have family and friends who listened and provided practical hands-on support. This was not the people that came and sat down and then you served them tea and lunch and everything. These are the people that came and folded the laundry, washed the kitchen floor, weeded the garden, did what needed to be done. Access to relevant and timely information was really important for these caregivers in order to feel prepared for caregiving, and they were highly appreciative of healthcare system support when it was needed. One of the things that these family caregivers talked about is the need for access to somebody 24/7. That doesn't mean that they want somebody to come into their home. That means that they have a phone number on their fridge that they are able to call and talk to somebody at the end of the line who actually knew something about palliative care. I'm happy to say that we have a 24-hour nurse line in the province now that actually provides that ability for people to have access. So we did all of these qualitative interviews with families, and we began to understand a little bit better the kinds of things that help people to cope with the caregiving. And then when we did these interviews, we also surveyed about 325 family caregivers. And we were really looking to understand the kinds of things that influence outcomes like quality of life and depression. And of course, because of what we had learned earlier, we were looking at things like optimism and resilience and how satisfied they were with the healthcare system and what the quality of the relationship was with the dying person. And these are some of the things that we found. So caring for, and they're actually not earth-shattering findings, they're pretty common sense, but caring for people with complex needs and high care demands is significantly associated with lower quality of life and increased levels of depression, but only for those people who appraise themselves as not being resilient or optimistic. So families really struggled with, when people got into a pain crisis at home, when people lost their ability to walk. But those caregivers that were resilient and optimistic really weren't affected by that at all. And the kind of take-home message around that is that there's beginning to be a body of research around resiliency interventions to help support families in providing care at home. Quality of life was higher for family caregivers who report greater resilience and optimism, good quality family relationships, and a strong sense of cohesiveness within the family. And so if you're somebody like me who is looking for, how do we design health services and interventions for family caregivers, one of the kind of red flags for me as a clinician will be how well does that family get along and what kind of social support network is available. Family caregivers who were more satisfied with healthcare services tended to have higher quality of life scores than those who were not satisfied, telling us that what we do in our delivery of healthcare is absolutely vitally important to how people perceive their experience. And family caregivers who feel better prepared for caregiving report better quality of life. It's interesting in end-of-life care, I know in the caregiving community in general, there's a lot of opportunities to kind of get some pre-preparation. And in palliative care, we tried to say, okay, well, how can we actually develop some educational programs for family members to help them to feel better prepared? But there's a real challenge in the timing of that, because not all people want all information at the same time, and some people are not able to kind of go there yet, and so the kind of programming around this has been really challenging, and also because families are they don't ever want to leave the home when a person is in the kind of dying process, because they're afraid that if they leave the home that the person is going to die and they will have missed that event. So it's like today, as I've been at the conference, it's got me thinking about technologies and how it is that we can actually help and support these family caregivers in palliative care, because they don't want to leave. Family caregivers who reported health problems felt that caregiving interfered with lifestyle and perceived caregiving as stressful, had greater depressive symptoms and lower quality of life. So we did that study, and what we kind of got from that is that we have so many families in this study who are really struggling with actually identifying their own needs for support, because families in palliative care don't actually feel that their needs are legitimate. And they don't feel their needs are legitimate because they're focusing so much on the dying person, and they don't want any attention taken away from the dying person. And yet at the same time, we know that if we could actually better help family members better identify their needs for support and do some proactive planning to support them, that the experience is going to be much better. So I'm in the process right now. We're doing an intervention with family caregivers. We have colleagues in the UK and Australia who are also doing this study, and we're looking at how it is that we can help identify family caregivers' needs for support in palliative care, so that we can actually do some pre-planning. And I don't have any data on this study because we're still in data collection, but what I will say is that this is a home care study, and from the time that I started doing initial studies in home care, maybe in the late 1990s and into the early 2000s, the whole home care landscape to me has seemed to change. And this is one of the things, aside from the intervention, that we're finding is that when I started doing this research, there was this real kind of closer to home push, and everybody's going to get resources and support in the home, and seemed to be going fairly well. And now we're going out into these families' homes, and we're talking with home care nurses who are involved in our intervention. And what we're finding out is that people are getting referred to home care much later we have people that we can't enroll in our study because from the time that they are identified as palliative is like 10 days. You can't do you can't do much when you only have 10 days. But families, the home care nurses are telling us now, and we're actually doing a side study from this because of this, but home care nurses basically are telling us now a couple of things. One of the things that they're telling us is that their practice has dramatically changed. A home care nurse said to me in an interview, she said, I've been a home care nurse for 13 years, and I used to be able to see about 12 or 13 people a day. She said, I can now see 4 people a day if I'm lucky. And that's because, she says that is because of the amount of paperwork that is required because of various organizational accreditation requirements and safety requirements. And so what's happening is that they're being told, only go and see family members if there's a crisis. Well, I'll tell you, a crisis in palliative care at home is a crisis. That's what takes people into the hospital when people get into intractable pain and we can't get on top of it in the home, which we normally could, no problem. And home care is basically being told, don't go and see people, have them call you. So I'm on the attack about this now because it seems to me that we're going backwards. I'm just going to switch gears for a minute to tell you about another study that I'm presently leading on equitable access to care for people with life-limiting conditions. And what I mean by that are sort of these concepts of how do we actually think about care and home and a sense of security when you don't have a home, and oftentimes when you don't have a family. So the people that we are studying in this study are people who are homeless, unstably housed, and otherwise marginalized. And I just want to start by telling you a story about Michael, who was a participant in our study. He died last summer. So Michael was a 7-year-old Welsh male. He tells us that he grew up in a good home. He said his father was a bit rough, a bit strict, had pretty high expectations in the family. And so after Michael grew up, he got married and he had 2 children and he was employed in the trades. And at some point in time, his marriage dissolved and he became completely estranged from his family. He had a work-related injury and that caused him to be unemployed and on income assistance. And he lived on a boat. He was diagnosed with advanced prostate cancer. Many of these folks actually don't regularly seek medical care because they're feeling entirely stigmatized. And so oftentimes people with structural inequities actually present to us with conditions that are highly advanced already. So he was diagnosed with advanced prostate cancer with very limited treatment options. At some point, he was hospitalized for kidney failure. He got treatment and he had to be discharged. And when he's in the hospital, his boat sunk. And he didn't have any place else to go. He's got no family that he's connected to. He now has no home, and the hospital discharged him to a single room occupancy hotel in downtown Victoria. I don't know how many people who have been in single occupancy hotels, but they're not exactly nice. He's highly mistrusting of the healthcare system. He actually has a really good GP that he's connected with, although he doesn't see him all that frequently, and he has a specialist. But he refuses home care nursing and home support because he feels judged by the people that come into the setting that he's in. His rent is about $900 a month, and he has about $450 left to live on for the rest of the month. He doesn't have the money or the ability to actually provide good nutrition for himself, never mind a quality of life. His dream is to build a boat and go back and live on the water. Actually, that's the thing that palliative care does, is try to actually help people to reach those kinds of things. A friend in his boating community helps him, and he secures some new digs, and I'll show you a picture of that in a moment. His friend was providing good palliative care. He can't afford the moorage, so he has his boat anchored out in the middle of the ocean, about a 30-minute row one way and a 30-minute row back. Okay, this is a 79-year-old man with advanced prostate cancer who is declining in health, and he's rowing 30 minutes back to pick up his prescriptions, to get any food. You know, it's that kind of situation. Over time, he gets progressively sick, weak, and fatigued, and he starts to experience unrelenting pain. He is dying. His boating friend actually provides palliative care to him in the final weeks of his life, because our health system is not flexible enough or not as rule-bound to allow one of us to actually row out there and check out how Michael's doing. And we did actually row out to the boat. It was actually great fun. Here he is. This is his. This is what he lived on. If you can kind of see the picture, he's got kind of a, you know, one of those trailer campers that attach to a truck, and then he's got kind of this boat and these pontoons, and that was his bedroom. That was some steps below. Sorry, I'm going to go back. I want to tell you what. So now let me just, I want the previous one. Okay. So what happened to Michael? So Michael's health was declining, and his friend from the boating community was going out and, you know, checking in on him. And at one point, a raccoon got on the structure. So he, so the next time that we went out to see him, he asked us if we would take him shopping to a sporting goods store so he could get a pellet gun. I mean, the things that you see in research, it's unbelievable. But anyways, he wanted to go shopping for a pellet gun because he was so afraid of what was going to be, you know, coming up onto his structure. What you can't see in this picture, but what you would see if you saw this in full view, is that Michael's structure is amongst us in Sydney Harbor, amongst many yachts and, you know, big sailboats and everything. It was, I'm sure to the people that live there, a bit of an eyesore. But that is where he wanted to be, that's where he wanted to live, and that's where he wanted to die. The problem was that he started to get so sick that he started to get quite unstable walking, and he was dropping his Dilaudid, which is the pain medication that he was on to control his pain, into the ocean, and there was a whole bunch of issues, and it resulted in his boating friend calling the Canadian Coast Guard, because that's who would be the people who would remove him from his ocean structure. He had a full ocean view up until about 2 weeks before he died. He was admitted initially to the hospital, to an acute care hospital, and my good colleague, Dr. Leah Norgrove, said, you know, this guy actually needs to go into a palliative care unit. He went into a palliative care unit, and when he was admitted, he was asked, who is it that you would like to be your main contact person? And he said, Ashley, who was the research assistant that is working on this project with me. He had to use research assistants as his main source of support, but it was Ashley who was able to actually get into that single room occupancy hotel, row out to that boat, and she became his primary source of support. And she was with him when he died. So why are we doing a study on structurally vulnerable people's access to end-of-life care? Because people who are impacted by inadequate housing, racism, substance use, and mental illness experience persistent health and healthcare inequities and challenges in accessing health services, especially at the end of life. Most people, if they don't die wherever they are in acute care. And for them, it tends to be a highly stigmatizing environment. Some people are admitted to palliative care units where care approaches might not be flexible enough to meet the unique needs of these populations. Some of these folks are still actively using drugs, for example, and that would be kind of a no zone within our current system. Many people die in places that we would consider unfit for human habitation, or in shelters or transitional housing where service providers may have limited training in palliative care or feel uncomfortable in providing end-of-life care. And when I say structural inequities, I'm talking about people who have unstable and inadequate housing, inadequate income, substance use issues, literacy issues, food insecurity, trauma, discrimination. Many people have had contact with the criminal justice system, and many people are estranged from their families. We are hoping that we can find some solutions in the services that already provide support for these people. But many people, these are data from Victoria, many people are turned away from shelters because there isn't any room for them. And by the way, if you don't know, when you live in a shelter, what happens in the shelter is that you go there for the night and then you've got to pack up everything and carry on for the day because the shelter's not open for you in the day. And boy, when you're at the end of life and you're trying to pack around your whole life's stuff on your back, it gets pretty painful. For every one person in shelters, there's 23 vulnerably housed individuals in Canada. So people who are homeless or unstably housed have about 75% have one or more chronic diseases, 28 times the rate of hepatitis C, 5 times the rate of heart disease, 4 times the rate of cancer. Some are severely depressed, and I can tell you that the population that we're starting to see are aging adults. The life expectancy is kind of short for this group of people, 34 to 47 years of age. People who experience structural inequities actually tend to get illnesses younger in life. We're seeing a lot of people now in their early 50s who are getting diagnosed with cancers that we wouldn't necessarily see well into the 70s and 80s. Mortality rates are 2 to 4 times more than the norm, and most people die in either transitional spaces. It could be parks, it could be a shelter, residential dwellings, the emergency department, and most commonly the acute care system. The homeless face many obstacles in attaining adequate health services. Homeless people have significantly less interaction with the healthcare community and therefore a greatly restricted window in which to attain palliative care. And concepts of family and home can be somewhat different from those caregivers that I've previously talked about. For many people who live with structural inequities and are also dying, constructions of home and family may be quite different. Many people living with structural inequities do not have the natural caring support network of a family. Instead of unconditional caring towards one another, a commodified system of caring exists, where you scratch my back and maybe I'll scratch yours if the price is right. Housing stability is also challenging with people typically living in transition between parks, downtown hotels, shelters, and the street itself. So many people actually become disqualified from disqualified from receiving community health services, including palliative care, because they don't have a stable home with a fixed address. And for those who actually have some kind of housing, many of these places are predetermined as no service for safety reasons. So palliative care is commonly provided by outreach workers, street nurses, and shelter workers who may not have any knowledge and skills needed to provide palliative care. And in an earlier study that I did a number of years ago, I remember doing an interview with somebody who's very well known in our community who said that, the community that is looking after these people are completely traumatized because they have no, when I work in palliative care, I'm working with all kinds of colleagues who know about how to talk about death and dying. But these workers actually don't have that kind of community of practice, which we're trying to change. Without the basics that a stable home provides, like shelter and running water and a place to store food, Many people in our studies have reported that people who experience structural inequities will seek palliative care in an inpatient setting, but sometimes they're faced with stigmatizing behaviors from healthcare professionals. A counselor that I interviewed said, people who are hurt and vulnerable need even more care, and they seem to receive less care. They are blamed and stigmatized and shamed for their lot in life, a lot of which has been out of their control. I think this is just so inhumane. And when you look at sort of the philosophical version of a perfect death and what the reality is for people, there's such a big gap there. I've had discussions with people who are sick and who are seeing themselves confronted with the notion of death, the reality of death, and the deep sadness there. They need to heal before they die, and they're not given that opportunity. This is tragic, to be still struggling with the basic entitlements of life at the very end stages of your life. It's criminal. So in the course of, and there's other studies we've done, but in the course of the research that we've done, we wanted to really start to think about how it is that we actually can help caregivers and what we have learned from caregivers about what they need for support when they're providing palliative care at home. One of the things that caregivers talk a lot about is the need for information about what to expect as death approaches. How long is it going to take for the person to die was particularly important for family members. Knowing what to expect is generally valued by family members and helps them to prepare emotionally for what is ahead. Disease and trajectory information, how to provide direct hands-on care, and how to get help when you need it is particularly important. Many people have not actually had experiences with caring for people. So, I remember being in a home and, even the language we use with people in healthcare, we assume that they know what we're talking about. We assume that if we say, well, can you actually move this, just move him in bed because, he's going to get a pressure ulcer. Well, people don't naturally know how to do that. We were not, I was trained to do that as a nurse, but the average person is not trained to do those kinds of things. So they need help. Information provided at transition points seems to be most helpful. So, there'll be a time when, say, the person who is dying is able to walk, but at some point they're going to not be able to walk. And it's usually when you see those kinds of changes or somebody actually is developing a pain issue or a symptom issue, that's the point at which information can be really helpful for people. Because if we kind of start from the premise of, okay, your relative is dying, and here we're going to give you the whole smorgasbord of whatever you need to know. People are highly overwhelmed by that approach. Many caregivers learn to provide care by trial and error, which sometimes results in success, but it's also described as learning the hard way, characterized by a high degree of uncertainty. Responsibility of learning how to provide medications and provide pain management creates a lot of anxiety for people. A lot of the tasks that family members are asked to do are tasks that were once done by nurses. And people are particularly anxious about providing pain control because, as I said, they're very worried that they're going to actually give the last dose of medication and then the person dies a few hours later and they think that they've actually participated in killing the person. Information needs to be communicated in easily understandable terms. Family members appreciate when they're not expected to understand medical language or when providers assume that they understand such language. I always, every time that I have an interaction in the healthcare system, I always do a little ethnography of my own. And so my daughter actually broke her arm twice, 2 different arms. She's 7. And she broke her arm and we had to take her to emergency and she had to have surgery both times. And I'm in the emergency room with her and I'm sitting beside a man who's come in. The curtain is drawn and there's a nurse talking with the man and a doctor because he has broken his collarbone and they are going to give him conscious sedation to pop that collarbone back into place. and they were trying to explain this to him, and they were using very technical language. And I could tell with the curtain between us that this guy didn't have any clue what they were saying. If I hadn't been a nurse, I would not have understood what that person just said to me. So, you know, when you're a caregiver and when you're already feeling a little bit anxious about what you're doing, we don't need to use we have to really be mindful of the language. The use of indirect cues to convey information can sometimes be unsettling, like, you should call your daughter right away, or, you know, they're moving the person to the palliative care room. People are confused by that kind of language. And what families overwhelmingly say to us that is really helpful to them, which seems like such a simple kind of thing, is that they want personalized, individualized care that acknowledges that the dying person and the family are unique human beings. And that relates to people's ability or people's desire to be known. Living well in one's final years is a universal aspiration. It is one of the greatest challenges, particularly for older adults. This group's increasingly complex medical and social care needs are shaped by multiple chronic conditions and comorbidities. Adding years to life is of limited value without adding a life to those years. Issues of death and dying are social barometers that measure our societal values and the social changes in which cultures engage. Death is a marker of social change in any given culture. For example, causes of death in Canada have changed from tuberculosis in the 1950s to cancer, heart disease, lung and kidney disease in current times. After-death arrangements have moved from the private sphere of the home to the public arena of the funeral home. Care of the dying has shifted from intimate loved ones to professionals, and now, as we are seeing, back to the family unit. As life expectancy rises and the age of death generally increases, so that most of us will die in old age, advocating for improved end-of-life care in a medical and social culture that strives for cure has not been without a challenge. Is our healthcare system as it presently exists up to the challenges? We are in a very good time to influence the future of end-of-life care in Canada, and this should be important to all of us, because if one thing's for certain, we are all going to die. Dame Cicely Saunders, the founder of the modern hospice palliative care movement, had a vision that was shaped by her personal history of working with the dying. I think that those of us who are involved with the dying likely have our own history to relate to as why we choose to work in this area. And so I will conclude with my personal reflection in hopes that you might reflect on how your experiences can be used to influence the ways in which dying people and their families are treated in our society. I've been a nurse for over 30 years, and for most of that time, I've worked in some capacity with those who are dying. Like some of you, I have been witness to some of the most profoundly moving experiences. I've also witnessed some experiences that have left me deeply troubled, and it is perhaps those experiences that have taught me the most. One of the first jobs as a young nurse I had in the mid-1980s was at a large urban teaching hospital. I worked on a medical surgical ward that provided care to people who had organ transplants. I had been working there for about 3 months after graduation, and I came on shift one day and I looked at my patient assignment, and there was one patient that didn't have a nurse assigned to him. Nurses always have that one patient that they remember. His name was Robert. He had been admitted the night before because he was rejecting a kidney that had been transplanted a few years prior. His immune system was severely compromised and he was very sick. I asked the head nurse who was looking after him, and she said that she hadn't decided, and I thought this was a bit strange. And then she said to me, he's not one of our typical patients. Along with rejecting his kidney, he was a gay man, had a disfiguring form of skin cancer, and he had AIDS, and he was dying. And this was in about the mid-1980s. And nobody wanted to look after Robert because everybody was afraid. Everybody was in a deep panic mode, in fact, that they would catch the disease. And when I learned that nobody wanted to care for Robert, I felt profoundly sad. I couldn't imagine what it must have been like to know that nobody wanted to care for you. And so I did care for him and his partner, and it was to be one of the best learning experiences. I was 21 years old. I grew up in a rural community, and if I had ever met somebody that was gay, I certainly didn't know it. The experience left me with a range of emotions. Robert's death didn't go very well. We weren't very good at providing palliative care back then. His death haunted me. It actually left me morally distressed, and I wondered about the injustice of it all. I kind of stuffed my feelings like a lot of healthcare providers do in these kind of situations because I didn't know what to do with them. And then I met Mary, or I supported Mary, and things began to change. So I want to tell you about Mary because while Robert inspired me, Mary compelled me. Mary was 59 years old. She was married and had 3 grown children, and she loved to fish. That was her fishing picture. And for most of her life, Mary had stayed at home raising her children, and in her later years became involved in running the family business. She was a deeply caring person and had the innate ability to see the good in others. She loved her children deeply. They were her life, and when her first grandchild was born, it gave her immense pleasure. Shortly after the birth of her grandson, Mary began to feel increasingly fatigued. She never liked going to the doctor and didn't want anybody to worry about her, but the fatigue continued and she developed a hoarse, dry cough. After a battery of tests, Mary was diagnosed with metastatic lung cancer. She went through a course of chemotherapy, but the chemotherapy made her sick and she became increasingly depressed and withdrawn. She developed excruciating headaches, and there was nothing that seemed to ease her suffering. After repeated visits to her oncologist, he told her it's all in your head and that her pain was psychological. I remember visiting her, and she couldn't even lift her head up off the pillow. Her husband was becoming increasingly frustrated and overburdened as Mary's condition deteriorated, and her children didn't know what to do. They were in shock at the anticipation of losing their mom, and they hadn't quite assimilated the fact that she was going to die. Mary lost her spark for life. She was doing all that she could to put on a brave face for her family, but she could not hide her unremitting pain. While Mary's oncologist was correct, her pain was in her head. It was eventually found that the cancer had spread to her brain, and the pressure from the tumor was what was causing her pain. When I saw Mary, her headaches had lessened with a course of palliative radiotherapy. But as her disease progressed and as her body weakened, she had a fractured pelvis. She had a urinary tract infection, a thrush infection in her mouth, and she was delirious. I was so angry that all of this had gotten so out of control, and I will never forget walking into her bedroom and seeing the complete look of agony on her face. This wasn't the way to die. And still, when she noticed me there, she smiled and she said, "Kelly, you always look so good in red." She was smiling, but I was crying because Mary was my mom. To say this was a life-transforming experience is an understatement. You can't go through life and not be changed by something like this. The experience our family went through changed the way I view the world and my place in it. I think it made me a better person, and I'm definitely sure it made me a better nurse. My mother died in 1990, and she was able to have a peaceful death with the help of some very talented and compassionate people in hospice palliative care. And perhaps hospice palliative care attracts people like me, those on a search to find better ways for caring for people who are dying and their families. And so perhaps our own history with death and dying can also teach us something about improving care for those who are wishing to die at home. Cicely Saunders once said, "A society which shuns the dying must have an incomplete philosophy." As we look forward into the future, I hope that we as a society will strive for a complete philosophy, one that embraces the dying and their families and moves forward with the vision that respects the dignity that they deserve. Thank you. And if you all still have energy left, I'm happy to take questions.
Well, I'm working with a gentleman who
Use
is...
the mic.
Oh, okay.
There's a mic, there's also a floor mic.
That was amazing. Can I come and work with you? I've been nursing for about 25 years, and I'm very inspired by what you just said. So many nuances. It was really beautiful. I think I had my biggest challenge in the last 2 weeks working with not a homeless man, but an Aboriginal man who has just found out a couple of weeks ago that he's got 6 months to live. And all of the horror of the residential school system is still raging through him. He's seeking solace through heroin and crystal meth and a variety of other drugs. And he's also deeply feeling responsible for his partner, who is also, you know, car accident victim 3 years ago and now addicted to heroin herself. And she's got limited mobility, so he's the one that goes and gets, he helps her. And right now he helps her by getting her heroin. And so I was, you know, we've got a couple of fantastic doctors working with this couple, and we're treating them as a unit, which is fantastic. But it distresses me that we have to, instead of just saying, you know, why don't we get you your heroin legally, we have to switch them over to methadone, which they don't have any relationship to methadone. It doesn't help them emotionally. And at this moment, you know, so we become like, we're saying, okay, well, this is good for you. We're going to give you this, but it really isn't helping them. Right. And I just read in the paper this morning that the federal government has approved some limited use of medical grade heroin to help people. And I just wondered what your thoughts were about that.
You know, people have a lot of thoughts about that kind of issue, but in my mind, it's harm reduction. And, you know, for a lot of these folks, you know, they're used to using certain kinds of things for themselves. And I know there's all kinds of moral arguments for, you know, why we might not want to allow that to happen. But if that's what's helpful for people, that's harm reduction. And, you know, the whole, we're in our equitable access study, we're now looking at sort of the conceptualization of a harm reduction approach in palliative care. Because it's like my colleague, they just released findings from a study of managed alcohol programs, and you know, it made the big news because it was like, you know, people in managed alcohol programs are getting a drink every 90 minutes. They're being given alcohol. Well, that's reducing the harms because they're not going out and doing something else, and it's the same kind of thing. But the situation around pain control is really challenging in that population. And it's sad. everybody just, oh, the wine's gone. I was going to say everybody just wants to get back to the wine, but I thank you for coming tonight, and I'm deeply grateful to Gloria and Sharon for the invitation to come and speak at the conference. I've felt so inspired today by the level of energy, and also just the number of people from the community that are here and engaged. So if SFU's kind of mantra is engagement, I certainly, see it here alive and well. So thank you so much. Oh, sorry.
My name is Johanna Trimble. I'm with the Patient Voices Network. I think at one point you talked about maybe 50% of people in residential care being on drugs that were harmful. I'm very much involved in looking at issues of over-medication of frail elders because of my own family's experience. And I'm wondering what percentage of people in the community who are frail elders who you think may be on drugs that are not good for them and may be harmful.
I don't know the statistics around that, and it's not really my area of research, but I would suggest that it's pretty high. What I see happening is, people are prescribed medications, and, they get prescribed medications in their 50s and 60s, and, they age into their 80s and 90s, and, your body changes, your metabolism changes, there's all kinds of things, but these drugs are never reviewed. Yeah. And so people stay on them, and more get added, and, pretty soon, nobody. So the role of the community pharmacy, in the community is a really important role, because those are often the people that actually are best suited to be able to do that. But I don't know if Gloria knows, but I would say that probably more people are getting medications and inadequate medications than they should be. One of the things I introduced you to my grandmother, and she's not on any medication. She's never been on any medications. 104 years old, and she says to me, well, I walk and I do things, but she says I'm not taking any drugs, and she doesn't actually need any for anything, but it's a factor in how people's lives are affected, for sure.
I just wanted to let people know that there's an initiative in Canada right now called the Canadian Deprescribing Network. And this is a number of organizations, doctors, pharmacists that are acutely aware of the problems of over-medication. So we're starting a network across Canada, and I'm part of the public awareness committee of the network, and I just want to raise people's awareness that they can request a medication review from their doctor and ask to have their medications reviewed. Often the doctor doesn't even know how many they're on, because there's many different prescribers, specialists, GPs, and so on. So I just want people to understand that you have the right to have your medications reviewed. Thanks.
Thanks.
Are there other questions, comments? Okay.
We'll take the start out. If you want to volunteer, what level would you step in at?
If you wanted to volunteer in palliative care? Yeah, so almost all palliative care programs in the province have a very strong volunteer training program. And volunteers are a huge part of the hospice palliative care community. So depending on where you want to volunteer, the best resource to contact provincially is the BC Hospice Palliative Care Association. But almost all, like if you worked in, or if you lived in, the area of Fraser Health, for example, there'll be an end-of-life program that has a volunteer program attached to it. So does Vancouver Coastal. So that would be the place to start. And most people tend to volunteer on inpatient units to start with. until they're feeling comfortable. And we have a number of community volunteers. The training around palliative care volunteering differs between where it is that you're working, but people are, there are training programs for volunteers in, I think, all the health authorities. Yeah, you're welcome. Yeah.
On a recent topic, what are your feelings about use of medical marijuana and perhaps de-escalating the war on drugs?
Oh, that's a big topic. Medical marijuana works really well for some people with cancer. That's been mostly my experience. I mean, the whole decriminalization issue is, I think we should decriminalize it because the strategies that we've been using so far are only putting, the people who have addictions to substances in jail and not the people who are actually selling the drugs. I'm quite in support of that strategy. Yeah. Yes.
One of the big concerns I have is in case we go back, for instance, way back to the dark ages, where we are not giving medication to those who need it when they're dying. We give it, it used to be, you cannot give morphine, for example, except every 4 hours. Well, when people are dying, they're not going to become addicted. It just makes them already addicted.
Well, people who have chronic pain don't become addicted to drugs because the drugs are being used to treat their pain. So it's a myth. Oh, it's completely prevails. And I'll never forget one time I was working with a family, and when I was working as a nurse, and I remember I worked as a clinical nurse specialist in palliative care, and I was working with this family, and this man was dying, and he had intractable pain. And he wouldn't take anything for his pain because he was afraid of addiction, and his family was very afraid that he was going to get addicted. And, he was on the palliative care unit, not on the palliative care unit, sorry, he was in an acute medical ward. And so I would just go see him frequently, and we explored kind of his concerns about, the use of a drug like morphine. And I after about 2 weeks, I finally, got him and his family to kind of say, like, the pain was very bad by that time, to try a little bit of morphine. And, he had quite a bit of relief from that morphine. So, just kind of worked along with family, because the other thing that people are afraid of when they're taking morphine at the end of life, sometimes when you initiate morphine in people that are terminally ill, sometimes it makes them really sleepy. And that's normal and common, but people don't want to be snowed over, so they can't communicate with their families. So, I'd been spending a lot of time with his family, and finally, we got this man's pain controlled. We actually got his pain controlled, and he was able to have really meaningful visits with his family. And then a nurse came on one night on the night shift, and his pain had increased, and he was asking to up the doses of morphine. And the nurse said to him, well, if we keep giving you morphine like this, you're going to become addicted and it's going to kill you. Well, I just thought, I've just spent the last 3 weeks with this family, but I mean, those views are pervasive. And, we can only just educate as much as we can to try to help people. It's the same thing with, everybody thinks that palliative care is for your last few days or couple of weeks of life. But, if you were here today, we know that early integration of palliative care helps people tremendously. There are trials, clinical trial evidence around that is super solid. So, people think that if we introduce palliative care, that, we're going to contribute to people losing hope. But, palliative care works alongside treatment. There are many people with metastatic cancer who are still getting treatment by the cancer agency, and that doesn't mean that they can't actually be being seen by somebody that has palliative care expertise at the same time. And we know when that happens, that people have better quality of life, they have way better symptom management, and they usually all have a plan in place, because people that talk about palliative care feel really comfortable talking about death. We're not afraid of it. And we talk to people, and it's not like I go in to see a patient and they say, I want to talk about my dying. I want to talk about me dying. Nobody actually there's a few people that come out like that. But most of the time, it's in those moments of, where people would say to you, not having a good day. And you would say, tell me about that. And it's in those moments of conversation that people begin to reveal where they're coming from. People are afraid to broach the idea with healthcare providers because most healthcare providers are uncomfortable and afraid to talk about it. And we need to do something to change that. Because if we can't talk about it as a healthcare provider, how do we expect to have any kind of conversations with families? So I said today, www.advancedcareplanning.ca. It is the absolute best thing that you can do for your family and for yourself, because we're all going to die. And at least, when my mother died, my father lives in Winnipeg. He's 85, and he comes to Victoria every year, and he spends 2 months in Victoria. And every year he sits me and my 2 sisters down and he goes over it all with us again. We've got it, Dad. We know what you want. But he understands the importance. Maybe it's because his daughter works in palliative care, but he also has had the experience of losing his soulmate and knowing what that was like. And what she experienced is not what he wants to experience for himself. It is the best gift that you can give your family, because it's terrible. All these cases of, all the cases in the newspaper about, people getting life-saving measures and everything, almost always it's because families have not talked about it, and everybody in the family is of a different opinion. No, we don't think that we should treat mom. Oh yes, we should treat mom. And mom's laying there and can't say anything, and then it becomes a crisis. So I don't want my kids to be in a crisis and be fighting with each other about what I want. I want my kids to know what I want, and then they don't have to fight about it. It's the best thing that I can do for them. So that was my pitch for advanced care planning. Yes.
What can families expect from palliative care at home?
Yep. So it depends on where you live, for one, because people in various areas in the province have better access to palliative care, even in the province. So, like if you live in Fraser Health Authority, woohoo, because Fraser Health Authority probably has one of the most robustly designed palliative care programs in the country. They have 8, residential hospices. They have consultation teams. So what you can expect is you can expect to be greeted by people who have profound expertise in the management of pain and other symptoms, who are well experienced in helping people navigate the healthcare system. They're well experienced in talking and facilitating family conversations. And really what palliative care is about is helping people to live up until the point that they die, and I mean live. So that's what you can expect. Yeah.
How does Coastal Health?
I'm not given a review of every health authority. I can tell you.
That's where most of us live.
Yeah.
It would be nice to know.
Yeah, there's a couple, and there's a couple of, there's a few, like there's hospice on the North Shore, there's a hospice downtown, there's a hospice out by UBC. And they have really, the palliative care unit, say at St. Paul's Hospital, is like 100%. They're fantastic. So, you know, there are services in most of the urban centers. There are good services. In some of the rural centers, you know, they find a way to put it together. And actually, sometimes they do a lot better than we do, even without having the specialist resources. But in Vancouver Coastal, there's a medical director for palliative care. You know, there are palliative care units at the Vancouver General Hospital, one at Lionsgate Hospital. So they've got a good team approach for palliative care as well. Yeah. And don't forget home care nurses, because if you want to stay at home, your number one friend is the home care nurse. And home care nurses have a lot of experience in providing palliative care. Yep.
I'm sure everybody in the room knows we're passing the legislation next month for medical assistance in dying. How do you feel about the fact that we passed that legislation ahead of making sure that people have quality access to palliative care?
Yeah. It's a fantastic question. It's going to be the focus of the 7-minute walrus talk that I do in a couple of weeks. I think that I think it's a sad state of affairs if medical aid in dying actually becomes the go-to strategy in the absence of good palliative care. That's how I feel. I'm not against medical aid in dying at all. In a way, I'm kind of happy because it's actually prompted this whole discussion about end-of-life care, and that's actually what happened in Oregon. You know, 18 years ago, Oregon passed its legislation. 0.2% of the population take it up. It's not a big thing, but they invested a lot of money in palliative care. And from my own experience, if you were here this afternoon, Doris Barwick, who's the executive director of the BC Centre for Palliative Care, spoke on this issue. But in my own experience, the people that I have met who have requested an assisted death, almost all of them, I would say, that got good access to palliative care, that request for death actually was no longer. There will always be the Carters, the Kay Carters, the Sue Rodriguezes, who really have a strong desire to have control. And that's what the legislation, I think, is meant to respect. But I think that I would be very, very disturbed if people are going in the direction of medical aid in dying without good access to quality end-of-life care.
There was a question over here.
Yes.
This lady here.
What do you think of moving St. Paul's Hospital?
I don't know. I don't even live here. I don't know. Yeah, is St. Paul's Hospital moving? I haven't heard that. You know what? I work with people at St. Paul's, and I did, when I was a student, I actually did I was going to school at UVic, but I came over to St. Paul's and did a 5-month rotation in their palliative care unit. And I love the location of St. Paul's. To me, it just seems like it's like a real heart of the community. And I always had such a good vibe in that hospital, even though it's old and all of those things. And I don't know if it's the faith-based influence or what it is, but I just, I hope they're not moving. I just think they provide a core service to the downtown core, and they're good at it.
There was a question, this lady over here.
I'm not clear on who pays for different types of end-of-life services.
Yeah. So palliative care is like any other health service. There's no extra cost for palliative care. Palliative care is part of the health authority. Where the cost might come in is that many times people are so overwhelmed with caregiving, and the health authorities will offer a certain amount of home support. So you have a home care nurse that goes into the home, but it's the home support worker. This would be, the equivalent to, say, a residential care aide in a long-term care facility. But there's a cap on the number of hours that home support. Now, there's strategies around that. We can request extra help for people, but sometimes families, they're so home support, we can't seem to get the same people coming into the home by and large. And so where costs come into play is that sometimes families will hire private care to come and help and assist. And there's lots of home support agencies that offer that service. But, to have access to palliative care physicians and palliative care nurses and home care nurses, it's all part of the services of the end-of-life programs in the health authorities. Yeah.
Well, please join me in thanking Kelly for a phenomenal talk tonight.
Thank you.